Good afternoon. The 20th Lourdes Manahan Lectures in Rheumatology is now streaming live from the University of the Philippines, Manila. I am Michael T. of the Division of Rheumatology, UPPGH, moderating this session. I would like to thank our sponsor, Johnson & Johnson, and all our participants for joining us today. Please post your questions at the Q&A box and we will address them during the open forum. You will receive your certificate of attendance a week after you submit the evaluation form and post-test. The link will be posted later. Be sure to type in correctly your full name and email address to receive your certificate. This is the 4th year of the LMLR that we are doing online. The LMLR aims to teach rheumatology to healthcare professionals, an advocacy initiated by Dr. Lourdes Manahan, the first Filipino rheumatologist. This year's theme is Life to the Max. We wish to emphasize a holistic understanding of our patients and their disease, as well as strategies through which we can make our patients' lives better. LMLR is in support of the WHO Sustainable Development Goal number 3 on health and well-being, and Sustainable Development Goal number 4 on quality education. The Division of Rheumatology has its book publications, the Atlas of Rheumatic Diseases in the Philippines and the Physician's Guide to Tele-Rheumatology. And those who wish to purchase copies can do so through our contacts. Our lecture today will focus on hand pain, how to differentiate common arthritis and soft tissue rheumatisms in the hands, and recognize patients who need surgical management. We are deeply honored to have two distinguished speakers. Both are graduates of the UP-PGH. Our first speaker is Dr. Eric Jason Amante. Dr. Amante completed his residency training in internal medicine in the University of Connecticut Health Center and fellowship in rheumatology in the Massachusetts General Hospital, Harvard Medical School Training Hospital. He is the section chief of the rheumatology in Asian Hospital and Medical Center and in Manila Doctors Hospital. He is a clinical associate professor in the UP College of Medicine and is the coordinator for service and advocacy and an active consultant in rheumatology fellowship training in UP-PGH. He is a past president of the Philippine Rheumatology Association. Our second esteemed speaker is Dr. Tammy Dela Rosa. He completed his residency in orthopedics in UP-PGH and had his fellowship in hand and upper extremity surgery in the University of Cincinnati in Ohio. He's the director of the Office of International Linkages of University of the Philippines, Manila. He is an associate professor and vice chair for academics of the Department of Biochemistry and Molecular Biology, UP Manila College of Medicine. He is also the vice chair for planning and development and program director of the fellowship training in hand and microvascular surgery of the Department of Orthopedics, UP-PGH. He is also an active consultant in Cardinal Santos Medical Center and the Manila Doctors Hospital. Ladies and gentlemen, let us welcome Doctors Amante and De La Rosa as they share their expertise in today's lecture.
Good morning, everyone. I'm Dr. Eric Amante from the Division of Rheumatology in UP-PGH, a clinical associate professor from the College of Medicine at UP. And I feel very privileged today to be given the task to deliver the lecture, When Hand Pain is More Than Overuse. I'd like to start by thanking our division for allowing me this privilege, especially our chair, Dr. Evelyn Salido, who works tirelessly to help our division grow and reach new heights. I'm also very privileged to share the stage today with, of course, Dr. Tammy De La Rosa, a wonderful colleague and friend from the orthopedics department, and of course, my good friend, and dare I say, future Chancellor, Vice Chancellor Dr. Mike T., who is our moderator today. I'd like to start with my disclosures. So the objectives of this brief talk are to differentiate the common arthritides and soft tissue rheumatisms in the hand based on clinical presentation, and to become familiar with the symptoms, signs, and important tests to allow us to diagnose specific musculoskeletal diseases better. You're all familiar with this figure from Harrison's. And when I teach and think about the hand conceptually, I really think about it in 4 sections, just as is illustrated this wonderful figure. We talk about the wrist area. We think about diseases like rheumatoid arthritis, pseudogout, carpal tunnel, and things like gonococcal arthritis. More radially, you think about problems like osteoarthritis of the CMC joint and the Corvain stenosynovitis. For the next ray over here, we talk about, for the MCP joints, rheumatoid, pseudogout, hemochromatosis. Further distally, when we talk about the PIP joints, we're usually thinking about rheumatoid, but also osteoarthritis, lupus, and even psoriatic arthritis. And for the very distal or DIP joints, we think about OA, psoriatic arthritis, reactive arthritis. Of course, these are just starting points for diagnosis. There are several types of arthritides and soft tissue conditions which can occur in the hand, which are not mentioned here. We shall go through several cases and hope to illustrate different diseases as we go on. So I'd like to start with this case, a very common patient to your clinic, a 40-year-old right-handed female who comes to you on medication for breast cancer, complaining of weakness, clumsiness, and numbness of her right hand. She has paresthesias, and often these wake her up in sleep, and she has to shake her hand to get things better. Examination of the hand shows mild thenar muscle atrophy and some weakness of thumb abduction. What is your diagnosis? So I'll give you a couple of seconds to peruse about this, but of course, this is carpal tunnel syndrome. We're all familiar with, but I'd just like to go over again the carpal tunnel itself. So if you look at the picture, you see the carpal tunnel made by the transverse carpal ligament, and of course the carpal bones. And we have the median nerve here illustrated in yellow, right at the center, and the 9 flexor tendons of the hand. And when there is a problem in this region, of course, there are specific areas affected due to the median nerve being involved. If we look at the anterior view or the palmar view, you can see that the first, second, third digits, as well as about half of the 4th digit, are involved in terms of median nerve coverage. And if you look at it from the back of the hand, you see more involvement of the tips of the fingers, again in the first, second, third, and half of the 4th finger. So CTS, or carpal tunnel syndrome, is probably the most commonly diagnosed compression neuropathy we find in the upper extremity. It's usually actually sporadic or isolated, but it can accompany many diseases, which we will cover over the next couple of slides. Some examples which are not well known are congestive heart failure, multiple myeloma, and even tuberculosis. Carpal tunnel syndrome is more common in women, prevalence rate 3:1, and about half of patients are aged between 40 to 60 years. Who gets it? Other people who get it. Of course, we know diabetics get it in a nice study of 18 pooled studies. Both type 1 and type 2 diabetics get it with an odds ratio of 1.69. In a study from Finland of 6,000 patients, patients with osteoarthritis were more than twice likely to have carpal tunnel than those without. And of course, in a study of 100 patients with RA, the frequency was more than 3 times higher compared to matched controls. Hypothyroidism has also been associated with carpal tunnel syndrome. We often get complaints or patients who come who get this during pregnancy. In a systematic review, 7 to 43% of patients got it during pregnancy. And interestingly, up to 3 years out, about 30% of patients still had carpal tunnel syndrome. Interestingly, aromatase inhibitors appeared to be associated with carpal tunnel syndrome. In a trial that looked at over 6,000 patients with breast cancer, they found CTS developing more frequently in patients assigned to the aromatase inhibitor anastrozole than in those who were assigned to tamoxifen, at a ratio of 2.6 versus 0.7%. So the classic constellation of symptoms patients complain about are nocturnal paresthesia, paresthesia or hypoesthesia in the thumb, index, and third and half of the fourth finger, and sometimes weakness or clumsiness of the hand. Patients often report forearm and elbow pain, aggravated by certain activities. It can be very poorly localized, and occasionally patients even have shoulder pain as a presenting complaint. I'm sure you're all familiar with tests for carpal tunnel. I just want to reiterate these. The Tinel sign on top, shown by radiating paresthesias in the median nerve distribution. You seat the patient with an elbow flexed 30 degrees and a forearm supinated, and then you gently percuss the volar wrist. And if there is a significant paresthesia, this indicates nerve irritation. Phelan sign, reproducing symptoms when the wrist is flexed for 30 to 60 seconds. A less commonly done but also important test that is more specific is the Durkin's test or carpal compression test. Paresthesias can be induced by 30 seconds of direct compression over the carpal tunnel. What about EMG NCV? Well, NCV testing should be used to confirm the diagnosis in patients, especially who have atypical signs or symptoms or are claiming a compensatable injury or a disability. Prolonged motor and sensory latencies across the canal can confirm compression of the median nerve. However, in patients who already have classic findings, the addition of electrodiagnostic tests does not actually increase the accuracy, so you can do without it. Now, if you have patients who may have cervical root compression or thoracic outlet syndrome or more proximal problems, the addition of electromyography of the cervical paraspinal muscles and proximal conduction tests may help. Let's look at the next case, a 45-year-old right-handed female who comes to you with a complaint of radial right wrist pain for 3 months, especially when gripping her plants, pots, and jars, obviously a plantita. So what does she have? This is probably your first look at the doctor who coined the name Dicker-Vein's tenosynovitis, as depicted here. I'm sure you're all familiar that this is a problem involving two tendons, the extensor pollicis brevis and the abductor pollicis longus, or APL. There's irritation around the wrist in the first dorsal extensor compartment. At the level of the radial styloid, these tendons pass through a tunnel composed of a shallow groove in the radius and an overlying ligament. It occurs usually in women in their 30s and 40s, but can develop in men and women of any age. Dicker-Vein's is the most common tendinopathy to develop as well in postpartum women, and this is because of the specific hand and wrist position, which is required when they lift an infant or they take care of an infant. Any activity actually requiring repeated thumb abduction and extension can make this problem worse. So again, pointing out the area involved. So patients report pain along the course of these tendons when they grasp things. There's tenderness and swelling, and sometimes there's even a creaking sound. And here again, illustrating that over the radial styloid. What about the test for Dicker-Vein's? The classic Finkelstein's test. So a lot of you may remember this from med school, where there is a forced ulnar deviation of the wrist with the thumb clasped inside the fisted palm. And doing this produces quite a bit of pain in patients who have this condition. It's pathognomonic. Our next case is a 50-year-old right-handed female diabetic who comes to you with a complaint of stiffness, pain, and snapping and locking of her second finger on her right hand when she bends and straightens the finger, especially in the morning. She kind of recalls a similar problem in her left hand, third finger, last year. What do you think she has? So this patient has trigger finger. or more formally, stenosing flexor tenosynovitis. This occurs in about 2% of the general population and is more common in women in their 50s and 60s. It can occur in one or more fingers in each hand, can be bilateral, can be sequential, starting on the left and the right, etc. And the thumb is thought to be actually the most commonly affected digit. The prevalence of this disease is also higher among patients who are diabetic, have rheumatoid arthritis, gout, or conditions that cause systemic deposition of proteins such as amyloid. So the main problem here is fibrocartilaginous metaplasia of the ligamentous layer of the tendon sheath at the A1 pulley, or the first annular pulley, as you can see here, with a secondary reduction in the cross-sectional area of the fibroosseous canal. And there is functional impairment initially as a result of mechanical impingement. And sometimes patients complain that they wake up and their finger is already in this state, or they bend it or flex it and they can't extend it anymore. So again, you see that illustrated here with mechanical triggering. And another test you can do is passive stretching sign for active tenosynovitis of the finger. With the hands palms up, you passively stretch the affected finger in an extended position. Now let's go to case 4. 45-year-old right-handed female, hypertensive, comes to you with 4 months of occasional stiffness and now worsening pain in some of her PIP and DIP joints and the base of her left thumb, especially in the morning. She's worried about diet. She's worried about things like lupus. What do you think she has? So to answer that, who are these people? So of course, these are Doctors William Heberden and Dr. Charles Bouchard. So the nodes and changes found in hand osteoarthritis are named after these two gentlemen. When we look at the American College of Rheumatology radiologic and clinical criteria for hand OA, it's mostly clinical. Hand pain or aching or stiffness on most days of the prior month, hard tissue enlargement of greater than or equal to 2 of 10 selected joints, less than 3 swollen MCP joints, particularly hard tissue enlargement of greater than or equal to 2 DIP joints, and then deformity of greater than or equal to 2 of 10 selected joints. Now, what you need to have are 1, 2, and 3, and either 4 or 5 of these criteria. If you have that, then you're defined to have hand osteoarthritis. 50% of this disease is attributable to inheritance. So if your mother had similar fingers, just check your fingers in a few years. You'll probably get them as well. So the prevalence of radiographically confirmed symptomatic hand OA was about 6.3%, slightly higher in females. However, radiographic hand OA in the United States has been reported to range from 27 to over 80%. So it's actually pretty common, but sometimes asymptomatic. There was an interesting study which looked at fat percentage associated with hand OA in males. Significantly elevated odds ratio of 1.34 and females 1.26. This is an interesting study which maybe suggests some component of inflammation because there's no clear relationship with obesity and hand osteoarthritis. What do we normally see? Well, some people find it confusing. They think people have rheumatoid arthritis. Of course, involvement of the DIP joints is more classic in OA and not really seen in rheumatoid arthritis. It's more of a bony enlargement, as most of you know. However, sometimes there is a lot of inflammation, especially when patients' bone enlargements are still growing. The nodes may be acutely inflamed. They may even be warm or tender. But again, they may also be bland and just hard, painless enlargements. It's often worse in the dominant hand. And if you look carefully at the CMC joint, there's often squaring, which represents a deformity of the joint due to osteophyte formation and joint space narrowing. Erosive hand OA may be its own certain thing. You see a picture here with a central erosion on the 4th DIP. And evidence suggests that this is particularly genetic, perhaps, with HLAs, IL-1 beta, and SERPINA1 genes being involved. There's a central erosion, not a marginal erosion as seen in rheumatoid. Radiography and ultrasonography are useful, and you'll actually see some biomarkers such as soluble IL-2 receptor and myeloperoxidase, identifiable in these patients. However, they're not yet useful in clinical practice. Let's go to case 5. So case 5 is a 36-year-old right-handed male smoker. He's got fatty liver, comes to you with an 8-week history of prolonged additive stiffness and pain in some of his PIP MCP joints. When further asked, he also has painful shoulder range of motion and has some swelling and pain in elbows and ankles. What does this patient have? Now, keep in mind, this is a male 36-year-old. And I can tell you now, unless things are very painful, I don't really see a lot of male 36-year-olds in clinic. Yes, most of them probably have gout or injuries, but males this age don't really come to clinic unless they have something severe and particularly persistent. So this patient has rheumatoid arthritis. I just wanted to highlight that in cases of rheumatoid arthritis, when you're sort of trying to think about what's going on, remember that if there's elbow involvement, wrist involvement, and particularly ankle involvement, that's usually not osteoarthritis. So that should already ping your radar to look for things like rheumatoid arthritis. This is the hand of the painter Peter Paul Rubens, his own self-portrait with what looks like rheumatoid arthritis. RA is relatively more common than certain arthritides. It affects 0.5 to 1% of the adult population worldwide, affects females more than males with about a 2 to 3:1 ratio. You're familiar with the shared epitope or susceptibility epitope, which has been described on DR4 beta chains with a great association with rheumatoid, particularly the ones highlighted here. And in some patient populations, up to 96% of patients who develop RA exhibit these HLA-DR loci. A person with a history of cigarette smoking in particular and 2 copies of this susceptibility epitope actually have an odds ratio of developing RA of more than 20 to 40 times the normal. So that's a bad combination to have. And the mechanism of this interaction probably is increased protein citrullination in smokers and the ability of the SE-containing HLA-DR molecules to present these proteins. So it's an interesting combination. Importantly, rheumatoid arthritis can present in different areas. So you can have ocular manifestations like keratoconjunctivitis sicca. You can have rheumatoid nodules everywhere. I've seen some in the lung, for example. You can have myelopathies. You can have C1, C2 subluxation, of course. That is articular, but it can present as something which looks more neurologic with a heavy head. Patients can have effusions. They can develop vasculitis. There's just so much that can also occur subtly in patients. And of course, they can develop osteoporosis, just secondary to the disease itself. The famous deformities of rheumatoid arthritis. So if you look at these, you have the swan neck deformity involving DIP flexion with simultaneous PIP hyperextension on the top. And then the boutonniere deformity, which involves PIP flexion and DIP hyperextension as well. That's letter B. And of course, the Z sign, right? Or Z-line deformity involving the thumb. So these are classic for rheumatoid. I've seen a couple of patients with psoriatic arthritis, for example, who have similar deformities, but these are, of course, very often associated with rheumatoid arthritis. And what's important with rheumatoid, as far as x-rays are concerned, you see marginal erosions. If you look carefully, I always order an AP oblique view, turning the hand a little bit so you can see the margins and see marginal erosion. Sometimes you'll see juxtaarticular osteopenia as well as cysts in the bone. Remember, this area is where the synovium develops pannus. And so initially that 2-cell lining layer area becomes hyperplastic and hypertrophic. And this is where a lot of the damage occurs. Of course, MRI is probably the best at still looking at changes in the hand, in particular for rheumatoid arthritis. So in patients who you're on the fence and you're not sure, and it kind of smells like rheumatoid and you want to make a quick diagnosis, occasionally you can go to MRI or even ultrasound actually, but more specific MRI to get a quick answer in terms of erosions, inflammation, and damage. The problem with MRI of the hand, it's costly and it takes a very long time to do. When we look at the American College of Rheumatology EULAR criteria from 2010, what's interesting in this criteria, changed from the old criteria, for those who don't remember, is that there are no x-rays anymore. So the joint involvement score of 0 to 5, depending on how many joints are involved, serologies, high positive rheumatoid factor, for example, and high positive ACPA or CCP antibodies, that's 3. And inflammation, abnormal CRP or abnormal ESR is a point, and duration of symptoms of more than 6 weeks is a point. So you have to have at least 6 points actually to qualify for rheumatoid arthritis. And let's look at our last case. So a 41-year-old left-handed male presents with a 3-month history of nail pitting. He's complaining a little bit about his right Achilles tendon. He's got a couple of toes he thinks are swollen, the second and third toes on the right. And he has a little bit of scalp itching and erythema. He has occasional lumbar pain as well upon waking up. It's been bothering him more lately. What does this patient have? So this patient has psoriatic arthritis, one of the great mimics of our world, because psoriatic arthritis can look like rheumatoid arthritis, to some degree can look like osteoarthritis, and even when it has spinal manifestations, look like ankylosing spondylitis. So recent data suggests that about 30% of patients with psoriasis will develop psoriatic arthritis. And in most cases, psoriasis precedes the joint disease. In about 15%, it's a tie. They develop together. But in about 15%, the last 15%, arthritis can precede your onset of clear-cut psoriasis. And this can present a diagnostic challenge if you're not looking for it. Psoriatic arthritis typically begins in the 4th or 5th decade. There are some associations such as HLA-C6, and of course, if you have spondylitis or involvement of the spine, a lot of patients will have HLA-B27 positivity. When we look at the Caspar criteria for psoriatic arthritis, there's evidence of psoriasis, of course, or current or personal history of psoriasis or family history, nail dystrophies or changes, which we'll get into, a negative test for rheumatoid factor, dactylitis. And dactylitis is interesting because when we look at a rheumatoid patient, it's just the actual joint, like the PIP joint that is swollen. But in dactylitis, it's a large amount of swelling, not just in the joint, but across the tendon. So it kind of looks like a sausage. And then number 5 is radiologic evidence of juxtaarticular bone formation. So this happens particularly periostally with psoriatic arthritis rather than rheumatoid. So you need to have at least 3 points of the following with inflammatory articular disease to be called psoriatic arthritis. Here's some of the nail changes you see. So there's nail pitting, horizontal ridging, onycholysis, yellowish discolorations, dystrophic hyperkeratosis. And this can be very subtle, especially in the beginning. Dactylitis occurs in about 30%. And the joint involvement for psoriatic, something to remember, often will follow a ray distribution, meaning up one finger rather than across with several fingers involved. It sometimes spares adjacent fingers. Arthropathy confined to the DIP joints alone, like osteoarthritis, can occur in about 5% of cases. And occasionally, you can have axial arthritis without peripheral involvement in less than 5%. And there is something called telescoping or shortening of digits because underlying osteolysis is particularly characteristic of psoriatic arthritis. You've heard of pencil cup deformities, and this is a very aggressive form of erosive arthritis, which is one of the sine qua non for psoriatic arthritis. So in summary, in the last 25 minutes, I've tried to go over several cases. As you see, hand pain can have several etiologies, both articular and non-articular. Genetics and certain coexistent conditions can increase the risk for specific diseases of the hand, and knowing some symptoms, specific signs, and important tests are really essential for you to early on pinpoint specific conditions and manage your patients better. Thank you very much for your
Good morning, everyone. Today, I have been tasked to talk about hand pain beyond the concept of overuse. I would like to thank the section of rheumatology of the Department of Internal Medicine for your kind invitation. I'm afraid that listening to Dr. Amante's wonderful lecture, I realize I may have some overlap with his talk, but please bear with me. Because hand pain is too broad a topic to cover in one session, we will focus on three conditions, namely carpal tunnel syndrome, trigger finger, and the vein tenosynovitis, three of the most common conditions we encounter in our clinic practices. Our learning objectives today are to understand how carpal tunnel syndrome is evaluated and treated based on best available evidence, and to understand the pathology of trigger fingers and what the treatment options are, and lastly, to understand the pathology of the Curvane tenosynovitis, its common differentials, and its treatment. Let's start off with carpal tunnel syndrome. A quick review: carpal tunnel syndrome is a set of signs and symptoms resulting from the compression of the median nerve as it passes through the carpal tunnel. The median nerve shares the tunnel with 9 tendons, and as the tunnel is bound on 3 sides by bone and on one side by one of the toughest ligaments in the body, the transverse carpal ligament, any condition that increases the volume of these tendons within the tunnel will increase the pressure inside. Carpal tunnel syndrome being one of the most common conditions affecting the population, there is a lot of information available. Unfortunately, some of these are of higher quality than others. The American Academy of Orthopedic Surgeons thus formed a task force to review the available information and come up with clinical practice guidelines and recommendations for the diagnosis and treatment of this condition. The best available evidence was evaluated and rated according to its strength and rated as strong, 4 stars, moderate, 3 stars, limited, 2 stars, and consensus, 1 star. So let's start off with diagnosis. Typical symptoms of carpal tunnel syndrome include numbness, tingling, clumsiness, awakening at night, etc. A review of the available evidence shows that no single symptom is the sine qua non of carpal tunnel syndrome. A single symptom alone has poor or weak association with ruling in or ruling out carpal tunnel. The diagnosis is best made when there are multiple symptoms present in the patient rather than just any one of them. One pitfall is failure to ask where exactly the numbness is in the hand. The typical pattern of numbness involves the fingers rather than the palm, and only the thumb, index, middle, and half of the ring. There are many physical maneuvers designed to detect or confirm carpal tunnel syndrome. However, as with history findings, each maneuver, when used alone, is not highly accurate, typically with a sensitivity of around 50 to 80%. Therefore, the evidence suggests that multiple maneuvers be done in order to strengthen both sensitivity and specificity. One observation when you examine a patient that has a high sensitivity rate is thenar atrophy. While there are other causes of thenar atrophy, its presence is a strong indicator that you need to consider carpal tunnel syndrome as your diagnosis. Many other diagnostic procedures and tools are in use, notably diagnostic scales, electromyography, and diagnostic ultrasound. Diagnostic scales like the CTS6, the Stothard questionnaire, and the Stirrat hand diagrams may contribute to the accuracy of carpal tunnel to the accuracy of the diagnosis, while diagnostic ultrasound has yet to be shown to be a useful adjunct in the literature. This is the CTS-6 evaluation tool, where a score higher than 12 means a 0.8 probability of carpal tunnel syndrome, while a score of less than 5 means a 0.25 probability of having carpal tunnel syndrome. Now let's take a look at treatment. Of the myriad treatments one sees in the literature, in advertisements, and brought to your attention on Facebook, Instagram, and by your neighbor, only 3 have strong evidence of efficacy. Two of these are non-operative, splinting and steroid injections. These injections have strong evidence that they decrease or eliminate the symptoms of carpal tunnel syndrome, although mostly temporarily. Still, other modalities show moderate evidence of efficacy. These are oral steroids, diuretics, gabapentin, vitamin D, NSAIDs, and ketoprofen phonophoresis. So overall, these may work. Still others show weak or no evidence of effectivity. There is strong evidence that magnet therapy is not helpful, and weak evidence that therapeutic ultrasound and laser therapy are effective. The third modality that shows strong evidence of effectivity in relieving symptoms and restoring function is surgery. Carpal tunnel release is actually one of the most consistently successful surgeries in the entire field of orthopedics. The evidence is also strong that by 6 to 12 months, the benefits of surgery are far better than non-operative treatment. Which brings us to a crossroad. When do we recommend surgery? The common practice is to start with a non-operative treatment, steroid injections or splinting. If and when symptoms persist or recur, these can still be repeated. However, once we have persistence or recurrence, surgery is usually presented as a choice. I hate to instill my personal opinion when discussing evidence in the literature, but here goes. In my patients, I recommend surgery right away if there is thinner atrophy. In cases where the symptoms are strong enough to waken the patient up at night, I also recommend surgery. All others, I discuss all options, and surgery is one of a list of these options available. Now let's talk about trigger fingers. Trigger finger is what is known as nodular tenosynovitis in our beloved pathology textbook by Robbins. In this condition, there is a stenosis of the A1 pulley of the fibro-osseous tunnel of the finger. It is one of the most common causes of hand pain and disability, and results from a mismatch between the tendon, which is a localized nodule representing thickening of the synovium, and the opening of the tunnel. It presents as, in order of severity, pain on gripping, clicking, locking in flexion, and the inability to actively flex the finger. A popular classification used by hand surgeons is the Green's classification. Grade 1 is pre-triggering, with pain as the most prominent symptom. Grade 2 shows catching. Grade 3A, locking. 3B has the inability to fully flex the finger. And grade 4 has a fixed flexion contracture. This picture shows where the pain is located in a patient with pre-triggering. The nodule can also be palpated at this area, just distal to the palmar crease. Management of trigger finger is less controversial than that of carpal tunnel syndrome. Thus, there is no task force to review the evidence or formulate recommendations. However, literature and institutional experience agree that the effective non-operative management of trigger fingers are splinting, steroid injection, or both. Choice of steroid is varied, and literature has shown that while some may have reported advantages, the ones on this list all work. Injection is frequently the first line of treatment. The overall success rate is decent, especially after a second injection, if the first does not completely eliminate the symptoms. Diabetics, however, have a lower success rate. A caveat in injection is that no more than 1 to 2 ml is injected of a cocktail of steroid and anesthesia. Splinting in trigger fingers aims to keep the metacarpophalangeal joint extended or at most at 15 degrees of flexion. This keeps the nodule within the tunnel, thereby compressing it with the aim of decreasing its size. It is worn for 6 weeks, and that explains why it is less popular than an injection. It is thus reserved for those reluctant to have a needle stuck into their hand. Surgical release is recommended when there is failure of conservative treatment or when there's already a fixed flexion contracture of the proximal interphalangeal joint. In patients with conditions that lower the success rate of conservative management, such as diabetes, connective tissue disease like rheumatoid arthritis, and gout, surgery is brought up as an option earlier in the course of treatment. A study in Germany studied the economics of this condition and presented a quick algorithm for the treatment of trigger fingers. It recommends that the injection is the first line of treatment, and a second injection is recommended if there is no resolution of the symptoms. If the symptoms do not resolve after the second injection, then surgery is recommended, either by open or percutaneous release. Last but not least, we discuss Decurvain tenosynovitis. Decurvain tenosynovitis is a condition where there is inflammation of the first dorsal compartment of the extensors of the wrist and hand. This compartment houses the abductor pollicis longus, or APL, and the extensor pollicis brevis, or the EPB. This condition is most routinely diagnosed by a positive Finkelstein's test, shown here in this picture. Of course, pain and tenderness are also significant findings. There are other conditions that may confuse the diagnosis of Decurvain tenosynovitis. Pain in adjacent areas may mimic Decurvain or may coexist with it, making treatment less successful. One condition is basal thumb arthritis, which involves the trapeziometacarpal joint. This can be ruled out in or out by a grind test done by exerting an axial load while rotating the thumb. Pain and crepitus are strong findings in support of this condition. Another red herring is intersection syndrome, where the same set of tendons, the APL and the EPB, rub against the wrist extensors and cause pain and inflammation. The pain in this condition is more proximal and dorsal, and on examination, pain is elicited with wrist flexion and thumb extension. Non-operative treatment is the mainstay of first-line treatment, and the best results are seen with steroid injections. While many advocate the intra-sheath injection, which is not only technically demanding and more significantly for the patient, more painful, it has been shown to be no more effective than injecting around the tendon and the sheath. Physical therapy and splinting are also effective, but more time-consuming and cumbersome, respectively. Shown here is a technique for steroid injections, injecting from distal to proximal, aimed at the two involved tendons and their compartment. While effective, there are documented complications of steroid injection for Dicker veins. Aside from injection flare, which is pain and inflammation in the injection site that lasts 24 to 48 hours, darker skinned individuals may show depigmentation of the skin or skin lightening. Associated with this is the thinning of the skin and atrophy of the subcutaneous fat, making the veins more visible and seemingly bigger. This condition, however, is temporary and usually recovers after a few months. Surgical treatment involves the release of the first dorsal compartment and is indicated after failure of conservative treatment. However, this procedure is more technically nuanced and involves common pitfalls. The anatomy of the compartment is variable, increasing the chance of complications like incomplete releases and injury to the overlying superficial radial nerve. The latter is a very painful and annoying condition and should be explained to the patient thoroughly before releasing. Again, let me interject my own opinion. I avoid surgical release for Dicker veins like I avoid COVID. A single patient with pain from a branch of the superficial radial nerve that has been irritated is enough for me to cover myself in personal protective gear and recommend non-surgical managements. Thus, although I see roughly 1 to 2 patients with Dicker veins a week, I release only 1 to 2 patients a year. That is how much I fear releasing a Dicker veins. My thanks to all of you, and I will be happy to answer any questions.
Thank you, Dr. Amante and Dr. Dela Rosa, for your lecture. We have some questions on the Q&A box, and allow me to read them for you. First question is there a relationship between Dicker vein stenosynovitis and pregnancy? The one asking the question states that she remembers that she had that after giving birth, and also recalls a friend who had it after she also gave birth. So is that just a coincidence, or is it really something that is associated with pregnancy and giving birth? Anyone can answer.
Okay, I can answer that, Tammy and Mike. So, well, it's a common, not just connotation, but it's a common thing that we see, patients complaining about this during or immediately after pregnancy, or even during breastfeeding. And a lot of it has to do with fluid shifts in the body, obviously, which happen during pregnancy and sort of postpartum time frames. So it's actually not unusual to happen. It can be bilateral and it can be prolonged as well, because obviously the next step is they'll be holding the baby, and therefore you can have symptoms again just from that perspective. So, but there is a relationship, and it's not unusual that it's not a coincidence that you notice this between you and your friend.
Thank you. Another question is Dr. Dela Rosa.
Yeah, I would like to just add to that, because I do see a lot of postpartum mothers, the first few months of child rearing infants, who have Dicker veins. Apart from the fluid shifts during pregnancy and parturition, I think a big factor is the thumb is not used to working apart from the hand. It's usually when we grip, it's closed. Now the thumb is used mostly in flexion. So this time during child rearing, when you carry a baby, the hand is always open. No, ganyan siya. And that puts a strain in some of the muscles that are not used to that position. I actually, because I see this also in patients, the not mothers who are taking care of children. So it's not necessarily from the pregnancy itself. No? Kasi kahit yung mga yaya, nagkakaroon yan. So yun. Sorry. Thank you.
Oh, thank you for that additional information. Yeah, so this is an advice, no? What therefore can you advise to our mothers or yayas who would be rearing their child or their children? Is there any way to avoid that? How can they not develop the decurvane stenosynovitis?
Maybe Eric, you first.
Oh, yeah, sure. Well, on my end, again, first of all, you have to see if there are other conditions going on, and then the method and people in general, well, this is just my bias. A lot of people are taking care of kids. They grip too hard also. So I think people just have to sort of know how to grip at 80% and maybe not extend their hands too much. You can change the angle at which you hold children to some degree, no? And of course, if it hurts or there are symptoms, consult a physician early on, right? Early on to get some more advice or medication. And of course, we have the other issue, which is what medications are or options are available. If, for example, you're breastfeeding, that's a separate issue also. But that's what I would advise patients.
Yeah, Dr. Dela Rosa?
I usually recommend exercises where you flex the thumb into the palm. A flexion of the thumb, both the MP and IP, theoretically should relax your extensors. Now, hopefully, preventing a strain. And I agree with Eric. If you're a mother holding your child and you have pain, please consult early because you don't want to drop your baby.
Yeah. This is also a question for maybe for Dr. De La Rosa. Is thenar atrophy still reversible after surgery? If not, what do you do in terms of surgical technique to allow the thenar atrophy to recover?
Okay. That's a good question because that's a question that's asked during our hand rounds when we talk about carpal tunnel syndrome. No? Thenar atrophy is a sign of a very severe and or long-standing carpal tunnel syndrome. So recovery is variable, but the answer to your question is yes. Thenar atrophy can recover. But if, for example, we're talking about a patient who is later in life, let's say 50 years old, 60 years old, who is bothered by it, and then has had that that condition for a long time, the chances of thenar atrophy is actually recovering is actually very low. So what we do is to do an opponent's plasty. We make a we do a tendon transfer to mimic, to replace opposition. So even if the abductor muscle does not recover, you will regain abduction of the thumb. So if you recover, then you will have two muscles doing the same job.
So thank you, Dr. Amante. So what are the triggers for you to refer a patient to a surgeon? Let's say you have a patient who has a carpal tunnel syndrome or trigger finger or decurvane stenosynovitis. When do you usually refer to a surgeon?
Yeah, thanks for that question, Mike. So, well, first of all, if you look at my lecture earlier, because of time constraints, I actually left out a lot of treatment, and I'm thankful that Tammy addressed those in his lecture. And as he mentioned, you can do conservative management first, and for example, steroid injections. But I do recommend that you abrogate the timeline a little bit. So if you haven't solved the problem in maybe 2 injections and a couple of months of treatment, then you can refer. And the other thing is, there's always nothing wrong with referring patients to ortho hand surgeons like Tammy, because whether or not surgery is done, obviously, um, it's a good opinion to have, no? Or at least the patient is informed. But for me personally, I'll try to treat it for a couple of months, 3 months. I'll make sure that the patient is also compliant with the recommendations we give them in terms of what they do, because occupation and recreational things that they do are have a very big impact on whether they're going to get better or not. If I've done that, for example, I've done a couple of injections, given a lot of medication, and it still hasn't responded, then I would refer patients at that point. Also, some patients present with more progressive symptoms like severe thenar atrophy, etc. So my timeline for that is shorter. I would refer those patients quicker.
Now, our talk is beyond overuse. I'd like to add a perspective. The hand beyond the hand. What are the common conditions beyond the hand that you think would be important to consider when we look at atrophy of the hand, clumsiness, and sometimes even patients with a gait disturbance already? So, and how would you approach these kinds of patients? Maybe 1 minute answer from each of you, because this is our last question.
Okay. Again, thanks to everybody who sent questions. We'll answer as many of them as we can. But for this question, I think it's important, whatever area of the body you're talking about, whether it be hand, foot, etc., that we are cognizant of everything else going on, particularly neurologically. We're looking for other neurologic problems, things which can mimic, for example, cervical neuropathy, etc. We have to check for neuromuscular disorders as well, and even circulation problems as well. So those are just things I would think about in approaching patients, particularly if they're not getting better.
For me, if you're talking about numbness and tingling and nerve pain, then I try to trace the entire nerve from the fingertips up to the neck to see where, if any, there are areas of compression. But in terms of overuse injuries, I think elbow overuse injuries like lateral and medial epicondylitis can contribute to significant pain and disability for a patient. But I agree, Eric, that the next differential for me is always a cervical radiculopathy. In fact, in my practice, the reason I do an EMG is to rule out cervical radiculopathy so that I can actually prognosticate better when I talk to a patient regarding his or her carpal tunnel syndrome.
That's all the time we have. And I thank our audience for your participation, sending your questions. And thank you, Dr. Amante and Dr. De La Rosa, for responding to these questions and explaining them really well. I'm sure our audience learned a lot from you today, and thank you for delivering this lecture really well. This afternoon, we had the opportunity to look at hand pain from the point of view of a rheumatologist and an orthopedic hand surgeon. We learned how to differentiate carpal tunnel syndrome, de Quervain tenosynovitis, flexor tenosynovitis, osteoarthritis, RA, and psoriatic arthritis. What I find very interesting in the talk of Dr. Amante is how he guided us on how we can almost differentiate these conditions just by looking at the involved part of the hand. Dr. De La Rosa's guide on when to recommend rest or splinting versus steroid injection, and even again surgical release, depending on the clinical presentation of the patient, will hopefully allow us to decide when to immediately refer to a hand surgery specialist. And that will be a more appropriate surgery rather than going through a step-by-step kind of an approach, because there are certain conditions, certain findings that will really point you to the direction of surgery rather than splinting or even an injection. So finally, I'd like to remind everyone of the link for the evaluation form seen in the chat box. To avoid any inconvenience regarding the certificate of attendance, please type in your complete name and correct email address where you want your certificate to be sent. We're currently working on the renewal of our CPD registrations. Hence, CPD units do not apply in this webinar, but you may still use the certificate that you will receive here for application of CPD units directly with the PRC. We would like to thank the Information Management Service Network team of UP Manila and our sponsor, Johnson & Johnson. Thank you all for joining us as we end this webinar. We hope to see you all on October 19 for the LMLR webinar on rheumatoid arthritis. Have a great afternoon and thank you.